Is this on?
It's not going to be mic'd or anything, but it'll record you.
Okay. How's everybody? Whoa. You sure it's not mic'd? How's everybody now? All right. So, someone's afraid to sit in the very front seat? You don't want that position? Okay. Is there... I go by Glenda's office. She's not here when I get here in the morning, and so.
$15 something like that.
Is there a form?
You can just you give Glenda the money and she writes down what sizes you want.
Huh, okay.
But all the money goes to Anesthesia Interest Group to help you anesthesia education awareness.
All right. I heard for the guys in the CA1 class, we're going to take up a bidding, and whoever gets the most vote has to wear an extra small shirt all day long, one Saturday on call. Is that right? That's what Mark was telling me. Okay. So this was called perioperative ACLS. I called this Anesthesia Centric because Carly Clark, myself, Larry Field, and Horst Rika, Will Hand, and Catherine Tobin are working with folks from the ASA and then a couple folks from the University of Chicago trying to actually put together and codify what would be a course that's very much so akin to ACLS, but ACLS is written for out-of-hospital arrest and general ward arrest, and it's very different in the OR and for the perioperative patient. So we're going to cover some of that today. So goals and objectives. We're going to, and some of the big stuff we're going to do today. Hello? How's her tachycardia?
Still there.
Yeah?
Gave her the lab thing, went down about 120s. She woke up, she thought it was a little anxiety related, so Ativan helped her, she was good for it.
Okay. So we're going to think about professional leadership, and that's very important in crisis issues. Talk about developing critical thinking skills. It's one thing to memorize stuff. It's another thing to be able to evaluate why is this 23-year-old tacky at 140 post kidney donation. Sort of talk about clinical context and help you all think through some of that today. Robert Christopher hopefully will be here soon. He and I were in a case today where we had a fella who his status post liver transplant was coming back for a trach. In the middle of it, there was a little bit of difficult airway stuff. He got a little hypoxemic and flipped into AFib with RVR and dropped his pressure. What would you do? That sort of stuff we're going to talk about today. Talk about a logical approach to unstable patients. And you can have whatever approach you want. I just want you to have something. And that's one, for the sake of your patients. Two, because on oral boards, they're going to ask you that. And there can be a lot of different ways to do the cases that they give you, but you're going to end up in a bad the patient in the oral board will end up in a bad situation, and you're going to have to be able to show them that you can think about it and think your way out of it rather than just having memorized stuff. We'll talk about what we've talked about before with y'all, but to reinforce sort of 5 major areas of instability. Use some problem solving as far as vitals, labs, physical exam. And the big thing is it's very good just to stop and ask yourself simple questions. Like, why is this patient tacky? Why is this patient tachypnic? Why is this patient obtunded? And taking in clinical context, taking in the surgical history that just happened, or maybe their preoperative history, or maybe something you've just done to them. And often we don't do that well. So what do you need in order to be a good leader? I would submit there's 5 things, and y'all have seen some of this before, but you need knowledge. You need good insight and judgment at bedside. Jarrett's got a young lady right now who's 23, donated a kidney today, has had a heart rate in the 130s for 3 hours in PACU, and they're saying, we need a bed, can't she go to the floor? That's a judgment and insight issue at bedside, and you need to be able to think through those things. You can have memorized all sorts of stuff, and in fact, all the med students, y'all know more about sphingomyelin right now than I guarantee you my residents do, but that fact that you memorized in med school At least it doesn't help you very much in anesthesia. I'm not sure if it does in other fields, probably in neuro. But learning what you do with knowledge is important. Anybody read poetry? None of y'all read poetry. Does anybody read anything?
I read stuff.
You read stuff. Non-medical?
Sometimes.
T.S. Eliot in Choruses from the Rock said, where's the wisdom that we have lost in knowledge, and where's the knowledge that we have lost in information? And when you memorize something, that's information. When I can, in the OR, ask you a question and you can actually dissect someone's pathophysiology and tell me what's going on and what we should do about it, that's knowledge. And then when you can take that same patient ahead of time and pre-op and make a good plan for them, and sometimes say, this patient just shouldn't have this case, that's actually wisdom. And so y'all are inundated with information hopefully today. Won't be so much giving you all of the data. Y'all can learn that on your own, but to help you think it through. You need to understand the environment. Where am I? Had a patient today, that one we went from OR 19, where we do liver transplants. I have everything I need. I've got the Jewett blood cooler out there and had all sorts of component products in it. Had airway stuff readily available. And then the case went up to interventional radiology, where we're in NORA, and it's very, very different. The machine is different, the setup is different, and your resources immediately available are different. So you have to know you have to not only understand the environment, but how does that affect your resources? And the biggest one that you have is personnel. Number 2 is equipment, but the first thing is personnel. Getting a second set of hands in there, a second set of eyes. But then also knowing about your equipment. We found out a couple years ago in a code in the hospital that there was a patient with a tension pneumothorax, and unfortunately all they had on the code cart were short 20s. So you didn't have a long 14 in order to decompress this lady who was 350 pounds. And so you had a patient who ended up being down a lot longer than they needed to for something as simple as this. Had nothing to do with cognitive skills, the insight and judgment of knowing what to do, but because these two things weren't put together well, and there wasn't good communication, someone had a bad event. And then the big thing is good communication. When things, and we're going to talk about this a good bit today, but when things start to get exciting in the operating room, you need to know how do you communicate about that. And in particular, you generally have 2 teams working in parallel. There's the surgical team, and their goal is to complete the operation, whatever that is. Then there's the anesthesia team, and we're there, like Dr. Dutton was saying on Monday, we're performing a supportive role, doing a few things. But you can get to the point with a patient where you have to say, not only does the goal of survival and maintaining what we're doing become more important, but you've got to steal people from their team. You need the scrub tech to do CPR. You need somebody to go get R2 pads. Everything else has to stop and reorient, and learning how to not be sheepish about that actually is one of the hardest things on this list. So, other than cardiac, what are the 4 other areas of instability? I'll give you a hint. It's right next, the lungs, right? The heart vessels connected to the lung vessels. All right. What's the next one? Neurological. All right. We'll see if I can actually keep you all from reaching a GCS of less than 12 today. Metabolic endocrine is the next one. What's the last one? Who's on regional? Who's been on regional this year? No, that's essentially a cardiac issue. GI bleed is a cardiac issue. Doesn't mean it doesn't need to be fixed, but it's essentially a cardiovascular issue. Right? Lots of local anesthetic going where it's not supposed to go is a toxin. Giving someone way too much neostigmine and oops, forgetting the glycopyrrolate can be a toxin. So beta blocker overdose can be a toxin. So the problem is, how many of y'all did OSCEs or are doing OSCEs in medical school where you walk up and you say, Mr. Henry, it's very nice to see you today. I'm student Dr. McAvoy. I'm going to be examining you. And all you have to do is you go like this. and you know that the note cards are going to come out with them telling you what's wrong, right? You just sort of have to make for the, and they're like, got a tension pneumo, which they really don't have. Unfortunately, people who have tension pneumos, they don't do that. They're blue. The lady that had bilateral tension pneumos in the OR the other night, her SATs went down and everything showed that she was having tension pneumos, but they don't do that. So you need to have a way to think through it and diagnose what's going on. So what I would recommend is, if we go in order of cardiac, pulmonary, neurologic, metabolic, endocrine, the first thing we need to start with is cardiac. And I know it sounds silly, but when how many of you think you'll do the Tanzania rotation your senior year, if you had to guess, the international rotation? Okay, you're going to go over there. Now, there's a lot of things that they do that are quite disconcerting. Don't get me wrong. But they will sit there, if they were doing a case on Jarrett, and they would keep their finger right on his temporal artery the whole time. Now, I'm not sure that sometimes the pulse doesn't go away and they don't move, but nonetheless, they've learned that you feel the pulse. And you look at the patient and you go, this guy's kind of red. If he turns kind of blue, that's probably sort of bad. But with all of our monitors and stuff, sometimes we don't actually do the physical exam that we should. So when you're an attending in 3 years and you get called in and it stops with you, you know, you say, okay, if I got called to the room quickly, what for? Does the patient have a pulse? Your pleth can tell you that. Your EKG cannot tell you that, right? But the best thing that can tell you that is simply putting a hand on the patient. Do you feel a pulse? Because often when you walk in and it's the case of, I think all my monitors failed at the same time, it's the patient. You know, if one of them fails, that's okay. If it's, I've been cycling the cuff for 15 minutes and my pulse ox isn't working, that's bad. So, but first question is simply, do they have a pulse? If the answer is no, stop surgery. And this, we're not going to go over a whole lot of the pulseless algorithms today. What I do want you to take into account, and we'll talk about it a little bit in this part of the talk, is that if it's VFib or pulseless VTAC, shock and shock early, but also take into account the context. And that's not out there yet that describes that well for us, except in things like an anaphylaxis that's worsening. You don't go ahead and give a milligram of epi. You may give 25 mics, 50 mics, 100 mics, and you're there to ramp it up, but you match what their pathophysiology needs. So if someone next year, y'all are going to do vascular, if someone's had a fresh carotid and they have a pulseless arrest and you give them a milligram of epi and then they come back and you feel good about yourself and their neck goes and the graft comes apart and all of a sudden they've got a gigantic hematoma and then they get a stroke after that, that's bad. So you have to take into account risk-benefit. And all of our arrests, remember, in pre-op, PACU, or the OR, and even the ICU, are monitored arrests, which is if you even look at the literature, that is a subcategory of pulseless arrest. And those patients tend to do a lot better because you get to bedside. The person on the floor that you find down, who knows how long they've been down, unless they were on tele or something like that. So when we were in the hospital with Ansley, the first couple of nights, the tumor was starting to actually compress her heart and lungs. Her heart rate was about 155. The only way that I could sleep was to have the pulse ox up so that I could listen to what was going on. And they would keep coming in and turning it down. And I'd get up and turn it up, and they'd come in and turn it down. I said, what are you doing? They're like, we don't like hearing those things. I'm like, then why is it on my daughter? The whole point here is to keep her safe. And so in the general ward arrest, that pulse ox is useless unless they have central monitoring. Because if it keeps alarming on that patient, they just go in and turn it down. And it doesn't matter that they have OSA and all sorts of other things. But take context into account with ACLS. The next question, if they have a pulse, are they stable or not? You know, if yes, what's the concern? So you can have the slides, Kim. You're welcome to take notes, but you're also welcome to have the slides. What's the concern? And I know that's important. This is huge when you're an attending. Oh, they were unstable. And you walk in, you go, wow, vital signs look good. heart rate 63, blood pressure is 127 over 68, you know, pulse ox, pleth isn't great, but it's reading 98%. Y'all feel pretty good about that? You nod your head and you walk out. You don't realize they just gave 600 mics of epi. The patient was 120 for a heart rate, and their SVR has gone, and they've got reflex bradycardia that's only going to be there for about 6 minutes. And you didn't look at their end tidal, and it's down to 22 because their cardiac output's nothing. And of course their pulse ox is reading 100 because they've turned them up to 100% FiO2. So if you get called and by the time you get there everything is stable, you better figure out what it was and why they're stable. Sometimes it's just stuff. On other times, though, we use potent enough drugs that we can make things look better shortly. So don't leave and say, oh, they told me it was fine. Always ask what's the concern. If they're not, call for help early. Joe Whiteley got called actually to OR 19 twice today. What's the context? And we'll talk about that. Okay? I'm going to tell you you have an unstable patient on OB. Give me some differential diagnoses. Abruption. What else? Abdu. Epidural overdose. Forgot that was a 60 cc syringe instead of a 20 cc syringe. She feels really good from here down, though. She can't breathe, and her heart rate's 24. But she feels great. All right, Brandon. Okay, uterine rupture. Okay, aortocaval compression. Pre-op. Patient's unstable. Differential. Could be bleeding in pre-op. Okay, so they just maybe just get sent up. Sure, and if they're next to the main OR desk, that's always a high likelihood, right? If they forego pre-op. Okay, what else? Arrhythmia. Okay, they have a dysrhythmia. Okay, and you see, none of those were the same simply by knowing the location in the hospital, right? And so those are things you need to start saying. What's the context? Location matters. Your environment matters. Central line has just gone in. What's high on the list? Sure, right? You ask who put it in, because then you want to know who to blame if there's actually a pneumothorax, right? And if they go, Dr. Henry, this is the one you put in. Man, there is no way this patient has a pneumothorax. Must be surgery's fault, right? Past medical history, right? If I tell you that you know that they've had a neurologic issue in the past, okay, let me give you this. 72-year-old lady presenting for head and neck cancer surgery that you're told is neurologically unstable. 2 days post-op, she was your patient, you're asked to go see her, and you know that she had a greater than 50% carotid stenosis on one side and greater than 75% carotid stenosis on the other. Does that affect the way that you make your hypotheses and refine what you think is high on the list? Sure, right? But often we don't take a break. We want y'all to memorize so much information, we never help you process it. And I hope today is a little bit of that. So past medical history matters. The other thing I would say is, once y'all get out and you're an attending, I hope you're scared to death. We're going to train you really well. I hope you're scared to death. All of you, I can't wait to do this. I think every June from now on, I'm going to have you read your personal statement.
I want to be the best anesthesiologist ever and be able to do any case in the entire world with my left pinky and still feel like I have lots of extra neurons left to do other things with. And then all of a sudden, your first day out, you get the patient with an LVAD coming for a lap chole. You're like, accept cases with LVADs for lap choles. And then your exception list gets really long. I'd been out about 6 months and I get this case. Hey, there's a patient coming down from the unit. She's intubated. She's been septic. She's not anymore. She's having a lap chole. She's got this, severe histiocytosis. Didn't help me a whole lot. I'm like, I have a concept of what's going on there, but like, I don't know what histiocytosis is. And I want you to know I love you guys, but y'all are guilty of this. You'll call me. You'll be like, yeah, the patient's on Januvia and Diovan and blah, 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 and aspirin. And I'm like, what's the Subuta? And you go, I think it's a And I go, what class of drug is that? It's a 2. Dr. McAvoy, we don't have a very good connection right now. So don't do that. If you have no idea what the pharmacology is, look it up. I had no idea what this stuff was. I PubMed'd it, and it's like only 10 articles, and all of them are death with sucks induction with this condition. I was like, okay. And we had been talking about the fact this lady had been septic. She needed to have her gallbladder out. She had been in the ICU. She was obese. She had been extubated earlier that day, yada, yada, needed to be intubated. We were going to do an RSI. And you go, if you don't know what the past medical history is, also take it into account. What symptoms are they having? And then what system do you think is involved? And of course, machines and monitors. We don't do that a lot here. Putting the patient on an ambu bag can take the entire anesthesia machine out of things fairly easily. Now, if they're on bivent or some sort of inverse ratio ventilation, that's sort of hard, but the point is, if you just get them on high flow O2, if you're not sure what's going on, it isolates your pipeline, everything else, as far as the machine goes. And then your monitors, they don't all fail at the same time, unless you're in a place where you have a power failure, and that becomes interesting. That happened to me in South Africa, and they wired this whole building to have one circuit, not with the rest of the building, because they knew it would happen a lot. And when that happens in the OR, they just plug in a lamp and bring it over and keep operating. It was interesting. Thankfully, we don't have to do that here. And then you need to ask yourself, what other info do I need? What am I missing to make the diagnosis and move forward? So, pulse or pulseless. What's really important here, if it is a patient not under anesthesia, are they apneic? Are they unresponsive? If they are under anesthesia, if you walk in and the end tidal CO2 is less than 20, and it is not that someone is trying to purposely hyperventilate, which you should never do that low anyhow. That's old dogma in neuro, by the way. And the no monitors working. But this one in particular, if your end tidal CO2 is less than 20, you're hypoperfusing. If it is 0 or less than 10, someone does not have cardiac output really of any kind. If you're doing adequate CPR, you will be able to get your end tidal greater than 20. If they're actually perfusing organs, and so it's a great marker. The best one to have is what as a marker of CPR? An A-line. Yep. If you have an A-line and you can get a systolic pressure over 60, it correlates with them doing better. Stable or unstable. So blood pressure up or down, altered mental status, really important, right? If you have someone who flips into AFib with RVR and they're still talking to you, they're still mentating, even if there's pressures low, you may not have to actually shock that person. Maybe you can chemically cardiovert them. If they're hypoperfusing their brain, then you need to. What else, if you think of altered mental status in the perioperative period, what's on the differential? Someone's in PACU, you have PACU resident.
Infection. Sepsis.
Could be an infection. Cam took care of them, and you think that they got really sick during his care. So sepsis could be. Stroke could be. Huh? Drugs, absolutely. Toxins, we do it to people, right? Yeah. So is it that you put someone into a cholinergic syndrome? Is it that they have a serotonin syndrome? Are they an NMS? Are they, are they altered mental status and floppy because they're hypoxemic because they weren't reversed appropriately? So low end tidal CO2 is a great marker. Heart rate, of course, respiratory rate. You can think through these things, but I just wanted to, I like repetition and redundancy to keep going through it. What's the clinical context? We talked about that, pre-op versus OR, PACU. Last year, someone was in the ICU for 2 weeks. They got extubated. They were out of bed to a chair. He wasn't doing well, had to be reintubated again, and got reintubated with sucks. Guess what happened? Hyperkalemic arrest. So taking the context into account is very, very important. If Bubba just placed a central line or a block, right? That patient's in, what I've heard, I don't know, Bristol said that they monitor your patients double for, put nurses on 1-to-1. I'm kidding. I had a buddy who was my senior when I was a CA1, and I was so thankful this happened to him. He was going to let me do this line. We're getting this cardiac case started early. We had been on call all night. We were helping somebody out in the morning. He was about to go on vacation.
And he's like, oh, you know, I want to jump in there and do lines. I was like, can I do it? And he said no. And then he started he was my CA3, he started teasing me a little bit, and he put a 9 French chicken foot into the carotid. You go, that sort of sucks. You know, that's the call you don't want to have to make. Hey, Dr. Brothers, I've got a patient I need you to see. Level 1 trauma, you mentioned, right? The patient that rolls to the main OR desk. And, you know, but you can think through these, but the point is taking a moment to sit back and think about thinking. What's the past medical history? We talked about that some. What are the symptoms or the most likely organ systems involved? And then do take a look. Do you know right now on all the machines that you use where to find the pipeline pressures or the tank pressures? Do you check them every morning? Yeah? Okay. Do you, you know, do you think about, you got high airway pressures, do I know right where the ambu bag is in the room, and I can get to it so I can isolate that whole thing and actually see, do I think it's a tubing related issue or is it between the endotracheal tube and somewhere down the patient's lungs? Those sorts of things are good to think about. And then again, what other info do I need? So if they're pulseless, there's only 4 pulseless conditions. PEA. So someone define PEA for me.
So
Electrical activity with a pulse. With no pulse. That's close. So's that and that, right?
So it can be, so VFib can be is a form of PEA.
Well, by semantics, yes, not by the way that you would treat it. Good. Well, it's not necessarily sinus, but it's a narrow complex. It's an organized rhythm without a pulse. Okay? Whereas both of these, and so you're still seeing normal ventricular conduction or fairly normal ventricular conduction. Okay? Versus seeing something that's completely dysregulated, and that's why you shock these and you don't shock these. Okay? So again, right now you'll use ACLS algorithms, but you consider perioperative causes. In the perioperative person, PEA is most likely hypovolemia. As much as I tell y'all don't just pound fluid into people, if someone arrests, we can always get fluid off of people. So most likely cause is hypovolemia. Anaphylaxis happens in the OR a significant amount more than it happens on the general care ward. Okay, what are the 3 biggest classes of things where anaphylaxis can happen to us? Antibiotics? Neuromuscular blockers? Huh? Latex, yeah. That's overblown a bit. No, so blood products, antibiotics, and neuromuscular blockers. Neuromuscular blockers are actually number 1. So anaphylaxis, we talked about atropine. This is out of the 2010 guidelines for ACLS, for PEA and asystole. May not be for us, right? If you're talking about someone who just got a retrobulbar block, you're talking about someone who is having a hysterectomy and they reach in and yank on the uterus. Insufflation of the abdomen sometimes. It's not wrong to go straight to a chronotrope, but sometimes if you have a very, very high vagal tone, you do need to break it. So that's one thing that's different. And the other thing is in local anesthetic toxicity, low-dose epi is better. So you want to be at a mic per kg or less rather than, if you think about a milligram in a 70 kg or 100 kg person, you're at 10 to 15 mics. It's actually been shown, at least in animal models, that that low-dose epi has a much better return to a perfusing rhythm than high-dose epi does. VFib, VTAC, defib as early as possible, and check all infusions to ensure that you have the proper drug. Very, very important when you think about, someone mentioned on OB, you got a pre-eclamptic. One night I was there at CA2 call, and I went in, and they said, you know, this lady's just acting funny. We wanted you to do the epidural. We just gave her some Nubane, but she seems way too sedate for just having had some Nubane. And they had switched her MAG and her Pitocin. And her MAG level when we drew it was about 7. She had lost deep tendon reflexes and was heading towards cardiac collapse. Which, what do you do, by the way? Before that? Good, stop the mag. It's stuff's real simple. It's sort of farm boy simple, right? You know, it's that bad. Anything that you look at and you go, that bad, stop it, and then do something else. And so if I can get that, y'all can too. I'm from Georgia, so I'm not very bright. And again, we'll talk about the communication of this. Our orthopedic friends, who are wonderful, smart guys, they like it if the patient goes into VFib, as long as you resuscitate them. The bone doesn't bleed for a little while, and they can get done what they need to. But you do need to address the patient care needs. And again, consider the context. We talked about that. Most of your patients that arrest in front of you, unless you've got a patient who is, already has horrible heart failure or something like that, coming for something, and they fibrillate, or someone who comes in and has a pH of, 6.5 or something like that, most people you're going to resuscitate. And most people who were stable before they arrested, you're going to be able to get back. So take in context, do you want a full arrest or a full resuscitation dose? Again, it's all war story stuff, but I was a CA1. We had a lady with gastric cancer. They had done a gastrectomy on. We take her to the PACU. She looks like she's doing great, develops massive ST changes, and then arrest right in front of us. And my attending at that time was a guy named Dr. Dorman, and he handed the phenylephrine to a nurse and said, hang this. And the nurse got really excited and just stood there and froze and squeezed the bag like this. And then he got the code card over, shocked the patient. I think I was probably cowering in the corner somewhere. He shocks the patient, running the whole thing himself, gives epi to the patient. Well, when we get the patient back, by A-line, her pressure was 328 over 160. We're like, we need to go to the cath lab. And we were afraid she was going to stroke out. And we look up, and the nurse that he had handed the phenylephrine to, the bag was about half empty after that several minutes. And we're like, what's the right answer to that one? Stop that. See? It's very good. Okay. A couple of things, performance and outcomes. Recent literature as far as pulseless arrest. If you looked at less than 2 minutes to defibrillation or greater than 2 minutes to defibrillation, this was about 1,000 patients that had VFib, VTAC arrest in the OR or a periprocedural area. If you shock early, you've got about 72% survival versus 60%, and this is only 2 minutes. The further you get, the worse it is. Survive to discharge, you are about 15% better. Independent predictors of delayed time to defibrillation. So this is really key. Do you know your rhythms? If the patient had VFib, they got shocked early. If they had a pulseless VTAC, they were much more likely to not be shocked on time. Okay, does that make sense? So if it's a wide complex and it's pulseless, you shock it. Does that make sense? Okay. If it was a cardiac patient, then they tended to actually be better monitored. All of us, CAD, we tend to have on the top of our radars cardiac of some kind, and you're actually half as likely to have a delay or more likely to get shocked on time. Okay. If you look at those that happened outside the OR, and you look at survival to discharge, you go less than 1 minute to 2 minutes, and then 3 and beyond, and it's a stepwise gradation down. Okay. Somehow in the OR, this it doesn't look like it has an association. What's really interesting, though, is the cases that happened in the OR were 360. Okay, you had 91 cases of missing time to defib in the OR. So why that is, who knows? And those cases were thrown out. So you've got something that would represent at least 20% of the cases you would be evaluating. So it's a bit hard to say exactly what that means, whereas you didn't have that in the non-OR cases. Take-home points: early detection is essential, early defibrillation is beneficial, poor documentation in the OR is common, and poor adherence to guidelines is common, okay? Because everyone in these columns right here had a witnessed arrest and had a delay to defibrillation. Okay, we talked about the clinical context. Now you can break it up more: pre-op, OR, PACU, OB, the ICU. what you want to say is you show up, perform a brief focused physical. If they're in the OR, look at the surgical field, take a look at the anesthesia machine and the vent, and assess all that information that's constantly coming to you, and to develop a way of doing that. What are my vitals? Include in your vitals your end-tidal CO2. What are my airway pressures? What kind of anesthetic are we doing? When you do this as an attending, you're going to have to walk in and quickly scan a lot of information. Okay, past medical history, y'all are physicians, you know this stuff, so I'm not going to keep hitting you with it. If you want to review the slides and say, are you scanning for all these type things every time that you're working up a patient is really important. And then family history of significant stuff to us, of course, MH, anaphylaxis, other things. Then, what organ system do you think is involved? From a cardiac standpoint, we talk about it all the time, but pumps, pipes, and preload, and then valves, vessels, and voltage. That covers everything that the heart can do. You've got your myocardium in there, you've got your valves in there, you've got vessels as far as coronaries in there, you've got your conduction system, and the muscle, of course, is your pump, and then your pipes are your peripheral vessels. And answering these things, if you think someone's hemodynamically unstable, if it has to do with the cardiovascular system, one of those things is going to be going bad. Okay? Or it could be the pulmonary system. Anytime that we intubate or extubate somebody together, I want you thinking through what is their oxygenation status, ventilation status, their mechanics, and their cognition. And if it's a kid with CP or something like that, it's not so much cognition, it's what do I think their bulbar reflexes are like? Can they protect their airway? Are they back to baseline? Okay? Do you think they have shunt or dead space? Do they have acute lung injury or ARDS going on? What's your PF ratio for acute lung injury? Less than 300, ARDS? Yep, less than 200, very good. Do you think they're main stemmed? Were you doing the laparoscopic donor this morning and the SATs dropped and you weren't sure if they had a pneumothorax? Or in rolling the table, did you main stem the patient? So always taking those things into account. Neurologic, how many of y'all actually did the stroke patient in ACRM last year? Yeah, there were, walking in and doing a physical. It can be very brief. Gross cranial nerve exam and motor and sensory exam can tell you a lot as far as, do you think someone's having a perioperative stroke? Do you think they're something with perioperative blindness? Bristol mentioned earlier, do you think you have opioid or benzo overdose, right? Is really important. Metabolic, understanding the difference between thyrotoxicosis, NMS, and malignant hyperthermia, guaranteed board questions. So when do you have increased end-tidal CO2, temperature, electrolyte changes, that sort of stuff. DKA and its treatment. Who was with me on call last week? You were, right? And we had the 600-pound lady with neck fash who was in DKA. So you'll get those cases, and you need to brush up on that sort of stuff, because that can be something that you quickly resolve or that you worsen. And then again, last, anaphylaxis. We talked about these things already. Now, y'all got this, right? I'm going to give you a little bit of a 3-minute break and see if this may feel like y'all for the week. Oh, please play. I'll have to send it to you. This is a Barney Fife reciting the preamble to the Constitution that he convinced Andy that I know all this stuff. So, case 1, you get this one. Come to pre-op, base 7 stat. Do you have to go upstairs? Okay. So, you're in PACU, right? Will you actually run up there and check on a patient that just came out from OR 14? I'll give you a pass. You'll have to do case 2. Okay. Cam, what are you thinking? This 3 years from now, y'all are in attending. What are you thinking?
Code situation.
Okay, code situation.
Unstable patient.
Okay. You arrive at the bedside. You're going to check the pulse?
Yep.
Right? What other information do you want?
Pulse stable, unstable. Talk to your nurse, see if the story,
Okay.
what's going on. Assess
Alright.
the situation.
So you're going to sit down next to Bubba. How you doing, Bubba? It's good to see you this morning.
Well, I
Can you tell me what was going on here?
Stable and unstable before that.
Okay. Was the patient stable or unstable before this? Is he breathing? What up?
Medication the patient
Okay. Did you give him anything? No.
Why are they here?
Why are they here? I don't know. Surgery.
I'm not going to talk to you guys. Why do I look straight to the patient?
Okay.
Because you're not giving me the information I need.
Okay. All right.
Is that
What if the patient was pulseless? Start chest compressions. Good. No, this happens. I don't know. Maybe I just have different stories, or I don't know. Maybe I do things really poorly. But I ran to a code the other day, and I ran the room and said, "What's going on?" They said, "The patient's in asystole." I said, "Really? How do you know?" They said, "Look at the screen." The monitor was not turned on. The EKG pads were still wrapped up in the wire in the rubber band on top of the monitor. I'm like, that's not asystole. That's off. We typically don't turn our patients off. Okay. So you got a 49-year-old white female presenting for left radical mastectomy for breast cancer. Anything different now? Okay. You asked, is she stable? Vital signs. This is what she is currently. Okay. You walk in, you ascertain that. What other info do you want?
What's pre and what happened?
Okay. So, previous vitals, what's been done? They had your kid right before you were called. They just bolused her paravertebral. Okay. So you're worried about last. What else? Yeah. You gave her 2 of Versed for her block. Whoops. I just gave the 15 cc's that you told me to work in slowly, Doc.
what was the medicine in the block?
What was the medicine in the block? 0.5% ropivacaine.
So the patient like hooked up the monitors.
Ah, that'd be a good thing. Yeah. So we have those. Those are the vital signs before placement.
Any cardiac issue?
Mm-mm. Hello.
Physical exam.
Hello. Hey, it's Dr. McAvoy. Good. How are you? I was just paged there. Y'all are done about the transport to the unit? Hey, are y'all about the transport to the unit? Okay, did the anesthesia tech make it up there? Can I talk to them real quick? No. This is the biggest problem. Now you've got to figure out, it's you, you're the attending. What do you want to do? Okay? So that's your EKG. Abdu. Good. You want what?
Get the cart at the bedside and
So you're going to go get the cart?
ask for the cart.
Excuse me. Can I please get the cart over here? Nope. I'll be up there in just a few minutes. Thanks. Good. So you call for help, and you, without being rude, you tell someone, Mark, you go get because you're really not asking. Mark, go get the code cart. if you want to add a please at the end, you can. And I don't mean to be silly, but at this point, if this patient has a pulse currently and is in pulsatile VTAC, what do you think's going on? I mean, that's flashing at the top of your differential.
He would be getting into systemic toxicity from the local.
Yeah, so you're thinking she's having local anesthetic toxicity, right? Let's list all the things that you need to do. Okay? Okay, so you call for intralipid.
You stop being
Huh?
You need to do ABCs.
Okay, so you do ABCs, and you have your vital signs, and...
I would bring some oxygen or a mask to the side.
Okay, you've got that on her.
Put pads on.
Okay, so you put pads on her. But think about this. So you want to get the cart to the bedside, you want to get R2 pads on her. What you want to get a face mask on her. What else you want to do? You want to get intralipid.
You want to see her access, make sure IV access.
Make sure she has IV access. Okay. What are you going to do?
I'll be directing her.
You need to be so you just listen. You have 4 people that you need doing stuff. Do you think that would be easy or hard in our pre-op area?
Very hard.
Right? So if Hannah's there doing the block, assuming there may be an attending that's there who then directs it, you've got Hannah, you need 3 other people doing stuff pretty quick. Okay? So the point is, treating last is actually fairly easy. Okay? As long as you can get the intralipid, you can get the code cart, you can have, the environment and the resources is the hard part. Does that make sense? So thinking through, how would you do that? When I got into this and got interested in simulation and all that stuff, it was actually my CA 1 year. I was in OR 6, and I started going through in my mind what I would do if. What if this patient fibrillated right now? What if this? What if that? And I was honest with myself, and I said, I'd probably, peel on myself, and then the patient would do poorly if it were up to me. Because I'd do this, and I'd do that. And understanding how to lead a crisis well is actually a really big deal. Okay, so possible problems. It may be that you don't know what it is. Some people freeze. For those of you who actually helped out at the simulation course at the Grove Park, you did. It was fairly surprising, the people in practice, that you had 4 people out in practice that missed MH together. That was bad. But your environment and your resources, then communication. And telling people, closed loop communication is huge. Mark, you need to go get the code cart, and when you get back here, you need to put R2 pads on. Drew, I need you right now to check if that IV is actually running and to get a second IV. Boom, boom, boom. And you're doing this stuff, and you're not leaving the bedside, and you keep a finger on the pulse in all seriousness, because if that patient goes pulseless, you need to start doing the treatment for them. Okay? And then all of that, this is insight and judgment. Right? This is the idea of where's the wisdom we've lost in knowledge, where's the knowledge we've lost in information. You can have tons of information up here and really stink at actually mobilizing that team and making it happen. Okay? So the leadership is key. Do you know where our intralipid is kept currently? Do you know who to go send to get it? How would you communicate to the pre-op nurses to do this? And just writing this lecture made me think, we probably need to start doing a drill once a month in the pre-op clinic. In the pre-op holding area. That would be hysterical to videotape tomorrow morning if we did that. It would. Yeah, that would be so YouTubeable that it's not even funny. And we need to. This came out just this year. I think it was February 2012 in Regional Anesthesia and Pain Medicine. It's the new checklist that's put out by by ASRA for LAST. And what I want to show you is, big thing, we talked about this already. Remember, context is important. You'll adjust your medications, and you may need a prolonged effort. There's been CPR done up to an hour in some people with CPC class 1 neurologic status afterwards. Okay? Whether that big bolus actually protects the brain is unknown, but it's witnessed, you jump on it, and if you do it effectively, you can have great outcomes. Okay? Individual epinephrine dose. This is the medical knowledge part. You walk in and you do standard stuff, and you can hurt the patient. Okay? So less than 1 mic per kg, very, very small boluses you want to give in this case. Understanding the lipid emulsion, if someone hands you a 10% bag, then the dose changes, right? So when you get the 1.5 mLs per kg, that's actually a dose you're giving in mgs per kg, but it's based on the solution type, okay? And then repeat bolus once or twice for persistent cardiovascular collapse, and then understanding that after someone reaches stability, you want that infusion for at least 10 minutes. So recognition, because it's such a hot button topic, fairly easy. You're going to give the person high triglycerides, so it's a pretty low risk thing to give even if you're wrong, okay? But where you can hurt the person is, oh, I memorized that dose. I know the information, but you don't have knowledge or wisdom. Does that make sense? So medical knowledge, thinking about it correctly, and then thinking through how would I lead a team if it were in fact up to me is really important. Okay. This can also happen. I had a lady a couple years ago who had a rheumatology friend of mine called. She was auto-amputating digits. She had such bad Raynaud's. And so they had tried everything that they could and said, can you try high paravertebrals? Or said, do you think you can do anything? I said, we can try high paravertebrals. We may knock out a stellate ganglion, and then we can get some vasodilatation in the hands. It actually worked. But she had bilateral T1 paravertebral catheters in for 7 days, and she started to get a toxicity very slowly. So the point is, if you're on regional, this isn't only for what can happen in the pre-op area when you're putting the block in. It can happen during a continuous infusion as well. In the same journal edition, they actually studied this, and what they showed was if you used this checklist versus did not, you did significantly better. In the pre-checklist items, as far as prevention and diagnosis, which the checklist doesn't have much on, there was no difference. It's not surprising. But for the ones where you actually use the checklist and the treatment items, the people did much better. Okay? And then they use this ANTS, which is anesthesia non-technical skills. It's not surprising to me that it didn't help with anything except decision making, because the decisions they needed to make were continue or discontinue infusion. Is the patient still arresting? What should you do? Keep going. The answer is so easy. Stop the bad stuff. Keep giving the good stuff, right? But it's very important to realize if you have a checklist there, it can give you a great mental help, but leading the crisis is a much bigger deal. Okay. So you get the following page. Please come to OR 5. Dr. Smith, your colleague was not responding. I need help with SATs. Okay? Jarrett, what are you thinking? Oh, Dr. Smith. Jerk. Lazy guy. Never does anything.
So you start thinking of causes of hypoxia.
Good. So major things. Are you ventilating? Causes of hypoxia. Okay, so you've somehow failed your daisy chain and you're actually giving a hypoxic gas mixture. Hypoventilation, possible. Okay. VQ mismatch, so we have some shunt. PE. Does PE cause hypoxemia? We'll talk about that later. Okay. What else do you think about?
You say hypoxia or
Huh? Hypoxemia. Yeah. Yeah, well,
okay.
they'll stand around and talk about it for a long time while the patient turns blue. Pneumothorax. Huh? Main stem. Yeah, sure. Absolutely. Okay. You arrive at the bedside. You're going to do those simple things. Patient's 49-year-old white female undergoing left radical mastectomy for breast cancer. The case started 10 minutes ago. That same left paravertebral catheter is in place. Aspiration and test. Hannah swears you're on regional this month, right? Hannah documented it is negative. Good level after bolus, and she stood by the bedside. She gave 15 cc's over 20 minutes, and that was 40 minutes ago. So, now what? Those are your vital signs. Huh?
What are your airway pressures?
Your ECG looks like this, and you want airway pressures. Okay, you're getting peak airway pressure. You're getting a tidal volume of about 385 on peak airway pressure is about 25. Huh? How big is she? She's 70 kgs. Does not have bilateral breath sounds.
Which trachea?
So check the machine circuit, check the tubes connected, and then add these two tubes.
Huh?
Add these two tubes.
Your tube is at
Title?
your huh? Very good. Okay. Your end title's 22. It was 38. Fluid's wide open.
Patient's coming unstable. Do we need to start some CPR?
Well, she has a pulse.
You said she doesn't have a.
Correct.
So where do you take
Which side is absent?
Huh? Left. You don't have anything. That's a good question. I'm not going to give. The patient's not going to reach up and go, feeling poor in this general area.
Is the trachea midline?
Huh?
Trachea midline?
Sort of hard to tell. She's totally draped. You know, they're getting started. So, you reach under, maybe. Head's turned to the right anyhow.
There's a left paravertebral block,
Yeah.
and
Needle.
she's got good left breath.
Uh-huh. No. No, she has absent left breath sounds.
Yeah, decompress.
Tension pneumothorax. Really? I'm just about to get started.
Stop this week.
Pardon me?
Stop the surgery. Patient's unstable.
I'm Dr. Cole. I'm the chairman of surgery. I'm taking this woman's breast off today.
Well, while you're there, just put a needle in it.
Patient's come first.
I understand that. She has cancer.
She's acutely dying this minute. I need you to stop her.
She's acutely dying this minute.
No, I'll convey to doctor.
Can't you? That's what y'all do. Fix it.
No, I'll convey to him the patient's vital signs and my concerns, and we need to stop now to check that the patient has, it's not a pneumothorax, and that's out from the paravertebral block.
But we're sterile. What do you need to do?
Concern and restart again if we make sure that nothing is wrong.
So you want me to take my whole prep off?
I'm sorry, sir. That's,
Okay, so take the whole prep off. Now what do you want to do? Hell no. Pardon my French, but no way. If I stick her chest, we can't do this surgery today. You're going to delay this woman's breast surgery. You're that certain of this. Pardon me? Just wait till I do Kohler. Right? The leadership part of that's awful hard. You go, she's just got a tension pneumo. I just want to throw the needle in. Now, right, there's a whole lot of stuff that has to happen. And you're going to put the paravertebral block on the same side as the cancer, on the same side where the operative field will be, and on the same side that if, we can blame it on Hannah since she's gone, if Hannah being on regional actually punctured the lung, then you would end up here, right? But that transition of leadership is quite hard. So none of y'all called for help yet, which would be a good thing to do. Okay. So you can walk through this, but airway pressure, you know, if you look at it, the big thing here too, if you put someone on volume control ventilation, it's actually not as good a ventilation mode, but it tells you a lot more. If you have someone on pressure control ventilation and you do not set your tidal volume alarm parameters, all of a sudden, she's not going to have high peak. What are your peak airway pressures, Abdu? And you're going to look down and you're going to go, 17? It doesn't sound like a tension pneumo to me. Right, but she's getting an 85 cc tidal volume, right? So knowing the limits of your stuff will actually help you lead when it gets to that point as well. Again, what's your venous access? We can go through all this stuff, but it's these same things. This part is the really, really hard part when it comes to Anesthesia Centric ACLS, because when you show up to a ward arrest, you've got one team working on one goal, and everyone knows that the patient has arrested. When you're in the OR, and we were primarily there for a mastectomy to have that patient do better and have a better quality of life, right? And we're taking care of their pain, we're doing all that stuff, but the primary thing is what the surgeon is doing, then it's a really big deal when you throw a wrench in that and you say, the circulator, that was the surgeon's circulator, and you just said that you asked him or her to go do something, right? Or told them to, right? Very politely. But the point is, you can begin to think about team dynamics, and if you don't do that, you're going to find yourself having a hard time the first times that you get into a crisis situation. And y'all are smart. Y'all are very, very smart, but the transition that you're going to need to make as CA2 residents next year is a big one. And if you see yourself as that person who, I don't really know how to stand up and lead, that's not going to be as good for your patient when you really have to, and the attending, for whatever reason, is a few minutes away. Okay? So we said diagnosis, there's your treatment. Unfortunately, it's into the sterile field, and there's all sorts of things to consider now because, right, if you do that and she has a catheter in her back, what comes next? Chest tube, even if it's a Furman, right? Even if you don't think this is anything that has fluid to it, she's still going to get a chest tube. So do you continue with surgery? Do you not? Do you drag cancer into her chest? Right? All really big decisions. So same thing is you being able to say, you actually said something really well, and you said it almost the exact same way that Corey first did on Friday. John Schaefer was playing the surgeon in the MOCA course and really pushing Corey hard. And Corey ended up saying, he said, look, if I don't do what I need to do and you don't stop, this patient will die in the next few minutes. Is the patient going to die if you stop what you're doing? And Schaefer said no, and he said, okay, patients come first. But you've got to know, and y'all were all making that point, but you've got to be that clear and communicate. I'm concerned that this patient has, fill in the blank, right? And then you say, and I'm concerned that if we don't address this, the patient may die. I'm not 100% sure yet, but part of that is because you can't auscultate the left chest that great, right? You snaked your stethoscope under and sort of listened a little bit, but if you have that high of a level of suspicion, when your end tidal goes from 38 to 22, you know, and you have no breath sounds and you have a causation on that side, i.e. a block that was just done, you know, it's time to think that way and put the patient first. And the big thing in all of this literature is the earlier you treat, the better people do. So, yeah, it really stinks if you were wrong and it takes 10 minutes to prep again. But if you let that lady go down, and she actually then arrests, and people are squabbling back and forth, and then she wakes up with a chest tube anyhow, a mastectomy, and a hypoxemic stroke, you haven't done her a favor, right? So, you know, the transition is the big deal in this case, okay? We will, I'm going to stop. I'm going to go through these quickly because I want to get to the end of it. Which quickly, someone read that blood gas for me. Well, assess the blood gas for me. I love you guys. Y'all are great. Assess the blood gas for me.
Metabolic acidosis and hypocalcemia.
So CO2 film as well. So you got a mixed.
You have a mixed what?
Well, you have decreased CO2. Well, it's not mixed, but yeah, it's safe minimum.
Okay. So you have a respiratory alkalosis with compensatory metabolic acidosis? No.
The other way around. You have metabolic acidosis.
Okay. This person is on the vent. So you've done this to them, but that's okay. So how many people say metabolic acidosis? Okay. Gap or non-gap? Okay. What's the gap?
So that's 15. So it's 20.
16 plus 105, everyone. 121. 142 minus 121. 21. Is that a gap?
Yes.
Yes. Okay. Very good. Who's on call tonight? Okay. Think how I'll drive home. So, do you need to give blood? 17-year-old, status post MVC. You give blood to this person? How many people say yes? Without knowing anything else, you'd give blood to that person?
I want to know whether blood pressure and oxygenation and all that.
Okay, so we do need to talk about that then, yeah. Because if you've just restored blood flow, you don't necessarily have to. The other thing is the function that you have in cells to scavenge CO2 is much reduced in blood that you have the hemoglobin to deliver oxygen, but the carbonic anhydrase inside the red blood cell to scavenge the CO2 is much less. So if you're just reperfusing, you may not need to at this point. But what would you definitely do for this patient? Good, absolutely. So this is actually, it's funny, I was with this talk, what Dr. Dutton actually put up in his presentation on Monday is this would be the guy who has just had lots of blood products given in a trauma and citrate toxicity. Okay. So same things again. Now, so that was the EKG, and you had that blood gas. What if that was the EKG? Hmm? He does have a pulse.
I mean, you think it would be like
Weak, but it's there.
some type of myocardial irritation due to ischemia causing the VCAT?
Yeah,
Could be.
right. So you can worry about hyperkalemia as well. You've just been given tons of blood products. Y'all are used to thinking about it with sucks. You have to think about it in any sort of crush injury. If anyone takes down a tourniquet that's been up for a long time in a trauma, particularly somebody's getting fasciotomies and a lot of blood-muscle interface, that could be a bad deal. And after blood. You start giving a lot of old blood quickly, you can have a lot of potassium if you have lyse cells. Okay? So you've got to be able to jump on top of that. H's and T's. So we didn't have enough time to get through all these. That same woman popping up again. Well, after Bristol needled her neck, she had to come back for surgery again. Okay? So now you come back. Something happens to her in holding again. Okay? So these are her vital signs. Same woman, okay? 49-year-old training for left radical mastectomy. Those are her vital signs. She became agitated before you were called. Paravertebral was placed 30 minutes ago. No bolus. Testos was negative. Hannah's there. It was definitely negative. Physical exam. So you look at her and you feel her pulse. It's there, a little bit thready. What else do you want to know from physical? Lung sound. She's wheezing. You ask her to be cooperative, and she's awake enough to be irritated with you. Doc, I'm just short of breath. Do something.
Skin exam. What's going on with her skin?
She uses oil of Olay night rub, and you assess that and tell her that looks nice.
Any allergic type?
Actually, yes, she sort of has this this rash and upper arm where the IV is.
Any drips going in there?
Huh? Good. Based on what happened last time, they wanted to do everything and be really, really careful, and so they decided to give her unison this time. You don't know why, that's just what they noted.
What did you
What's she allergic to?
Well, she came in one time, and the poor woman had local anesthetic toxicity, and the case got canceled. And then the next time, Bristol was convinced that you gave her a tension pneumo. Does she have an allergy? No allergy. She's never seen the doctor before. She's a 49-year-old who's healthy. right? What do you think it is? So there's this thing that a joke, if you grow up in Baptist churches, there's the joke about you got a kid in Sunday school. You say, okay, Johnny, what is about this tall, has a big furry tail, sort of goes like this with acorns, and it's sort of grayish brown? And he goes, sounds like a squirrel to me, but I'm going with Jesus. Right? What is this? What does this lady have? Absolutely, she has anaphylaxis. But you have to be careful, because if last week you had the same setup of a person, you're going to be on service and you're doing all these paravertebrals, right? What could happen with paravertebrals? Tension pneumos can happen with paravertebrals, LAS can happen with paravertebrals, or the patient can have something totally unrelated, and you have to make sure not to have blinders on.
Anaphylaxis 30 minutes?
No, she's getting an antibiotic. They decided to, she's had so much trouble before, we decided to do something different. And my point is, you've got to step back, and if it doesn't fit the picture, then you need to say, so it's a great thing. What meds and drips were going in? So Unison was dripping in. What do? Stop the Unison. All right. Okay. Now, last thing, and we'll go. 10 seconds for 10 minutes. Okay? Take control, calmly but firmly. Okay? If you don't know what's going on, everyone stops unless someone's doing CPR. If you get in and it's confusing, you go, everyone, stop. Just stop what you're doing. Okay? Communicate to the team. What do we think is going on? What have you recently given? Everybody quickly give me 3 seconds of what they know. You gather information, assign roles, refine your differential. Okay? I heard a guy one time, it was one of the best workshops I'd ever been to, that said, let the patient die for 10 more seconds and they might live. Okay? If you get people flying around doing all sorts of stuff, you've got the person holding the neo bag, right, doing this, and the pulse returns at 328 over 160. That's not good. That's a little elevated, sort of stage 4 hypertension. But if you don't know what's going on, you need to think about, how would I lead something that just involves an area that's not set up for leadership? How would I lead when there's a team transition of care? You're telling the surgeon, I really need you to stop. And then how do you lead when you think it was one thing, you're convinced, man, I'm getting called to Bay 4, we just finished that paravertebral, I know what's going on, and you show up and it doesn't fit that picture. Okay? Stopping, reorganizing, and moving forward is a very important thing to do. Okay? Same thing as always. I'm going to get to the end. It's funny, this was sort of a case that somehow it predicted what we had today. What I want to get to is this. Use of a checklist to help. I handed those out to you. We talked about wanting to do these things. And what I want to end with is I really encourage you to use those. You've got this checklist for the OR. This was it. So failure of adherence to critical steps in management. And now we have this same data on y'all when it comes to the 2-person model that we used last year. Some of y'all went through that in June. Some of you didn't. But if checklists were unavailable, a quarter of the time the team did not get to Brandon's step of stopping things, whether it was MH and stopping a volatile, whether it was stopping an infusion of a drug giving anaphylaxis or something like that. If you have them available, it went down to 4%. So I would encourage you. These are very simple. It's something that we may start to do. Susan Harvey's maybe in charge of this, doing this statewide and rolling them out. Have them with you, and it's a good check. The stuff that I'm working on, the apps that I'm working on, I show up to a code, I use it. It's not it's an absolute crutch, and I'm thankful for it. Okay, cognitive aids help. Medical knowledge is only one piece of leading the team well. So, sorry that took longer than an hour, but hope it challenged you to think. Any questions?